I'd like to urge everybody to take your seats. We love the networking, but we want to get on with the program. Hopefully everybody will have time to network at the lunch session. It's wonderful seeing everybody networking. This is great. So I'd like to introduce our keynote speaker, and she has a very lengthy background that I'm going to try to capture to give you the essence of how impressed we are that we have her here as a speaker today. She comes to us with a PhD from the School of Public Health at the University of North Carolina at Chapel Hill, one of our competitors. She also has an MPH in Population Studies from the University of Texas Health Sciences Center. She was an associate professor and a full professor at the University of Texas School of Public Health in 2002 to 2007. Before that, she was at the Arnold School of Public Health at South Carolina. She's now Associate Dean of Research, Professor and Endowed Chair in the Center for Research on Violence Against Women. She also has appointments in the Department of Epidemiology and the College of Public Health and Obstetrics and Gynecology and the College of Medicine at the University of Kentucky. She has taught a number of graduate level courses in epidemiology and has advised a number of graduate students for their capstones, practicum experiences, and dissertations. And we're just absolutely delighted to have Dr. Ann Coker with us today. I didn't tell you her name.
Well, thank you very much. I would like to say that the University of Kentucky School of Public Health has space like this, but it is not true. This is an amazing location here, really amazing. All right, so I am going to be presenting, and I have a significant taskmaster in these two fine women here in terms of what we're covering. Michelle asked me to cover pretty much the kitchen sink as it relates to the science or the state of the science in terms of particularly screening, but really covering the range. So here we go. I'd also like to say that I tend to, even though I'm from South Alabama, I tend to speak pretty fast. So if you cannot keep up with, or I'm speeding along too fast, please give me the signal or something like this so that I know to slow down just a bit, okay? All righty. So I wanted to give you an idea of what we're going to cover. What I'm going to cover today, I'm going to basically give you a brief review of what I'm calling the pre-intervention research. This will probably be briefer than I initially intended because we have a very educated audience here. So I'm going to really briefly talk about what essentially the prevalence and incidence of intimate partner violence and sexual violence, and provide some very new evidence or information that's just come out. Then I'm going to provide a review of the intervention efforts by prevention level. So starting with tertiary, secondary, and focusing on screening, because I think that's the theme of the day, and then end with prevention at the primary end of things. So I'm going to present that in the frame of what works in terms of the evidence base that we have, as well as what might work. And we have some new evidence along those lines, very much from the just spit out from the computer, as well as in the pipeline in terms of prevention. I like that theme. Thank you, Rachel. Rebecca, excuse me. Okay, so let's see. I'm starting then with the prevention research to date. Much of that needs to be and has been, and I've participated, as many of you guys have, in those efforts of defining or really defining the phenomenon. And we have Linda Salzman and her work at CDC and many others to thank for that. A lot of work has been done in terms of measuring the frequency of intimate partner violence, sexual violence, and the range of other related phenomena that we've had people talk about actually this morning as well. Also looking at the physical and mental health impact. Our last speaker talked about that as well, and I'm going to cover, this is essentially all the stuff I'm going to cover before we get to what works and what might work, okay? So you know what you're in for here. Okay. And then we're going to focus, and much of the pre-intervention work has focused on victims, and more recently has focused now on perpetrators. Victims, because they are easier to study. However, the problem is the perpetrators in many ways in terms of research, but also in terms of those injuries that we are trying to prevent. I would also like to say, just a brief vision conferences in the future, but that's not possible. So we need to do what we can with the time we have allotted so that we can prevent violence against women and violence against men. All right, with that said, that's my editorial for the day. What I'm going to start with is a very general, and this is probably everybody in the room knows, but I'm just going to state it. This is data from two large studies that were conducted, the National Violence Against Women Survey, which was conducted in the mid-90s. And what I'm presenting here are the frequency of intimate partner violence as well as sexual assault and specifically attempted or completed rape. And what I'm doing here is presenting what numbers from the National Violence Against Women Survey, which actually included men, as you can see here, and then the more recent Newsvids, which is the National Intimate Partner. The P got dropped from Newsvids, and Sexual Violence Survey. Both surveys had similar numbers. There were about 16,000 men and women in both surveys, slightly more with Newsvids. Newsvids was recently reported to the end of 2011. So about 10 years difference in time, a little bit more, 10 years difference. Bottom line here, because we're having several bottom line slides here, is that about 1 in 4 women reported, and these are population-based surveys, large population-based random digit dial surveys. About 1 in 4 women report being physically assaulted, so we're talking more severe forms of physical violence, not including psychological abuse in this particular slide, or they were raped. 1 in 4 women, and you can see the proportions here. And then 1 in 10 men report rape or physical assault by a partner. Partner can be in both situations, either gender, and when we're talking about partner, we're talking about a current current boyfriend, girlfriend, or our current spouse or ex-spouse. So that's just the bottom line here to give you some sense of the frequency of this violence. Also, if you have questions, I'm happy to take questions during them, particularly if they're clarifying questions, because I don't want you to have a burning question and not be able to ask it as it is relevant, okay? All right. I mentioned that the National Intimate Partner Violence, Sexual Violence Survey was recently published in the last year, and I'm just showing you this so that you can go to that for this information. I'm going to present some data from this particular report, largely because it is probably the best data we have in terms of the prevalence and incidence of violence. Okay. This survey, just real briefly about the methods for the survey, I'm an epidemiologist and we tend to be stuck in numbers. It's really hard to get the qualitative work I cannot get, but it's very important. But numbers are where we live in the epidemiology world. So this was the real contribution of the Newsvids study is that it is, again, a random digit dial, so a population-based sample. They used a dual sampling strategy to include not only landlines but cell phones. Cell phones are wonderful for us all. The problem is they make things like random digit dial very difficult. So they've included that. They did not include that in the previous National Violence Against Women survey because cell phones had not caused the problems that they currently cause for us in these kinds of work. So you got the numbers in terms of the proportion, a little over 50% were cell phone calls. This was conducted to be nationally representative. There were individuals from all 50 states, again, men and women. The survey actually included victimization as well as perpetration. Centers for Disease Control and Prevention is not reporting in this report perpetration data. Okay, so I will present some perpetration data from studies that we're doing in the University of Kentucky. Okay, just to give you an idea, again, frequency is point number 1 that I'm covering. Okay, response rates are provided here. About a third of those individuals who were in sample participated. The actual cooperation rate, which means basically they reached them and they said, I'm using my prop here, and they said, sure, I'll do the survey, is 81%. Okay, all righty. So I'm going to another one of my missions is to provide you with definitions, and then to provide you with the prevalence here is what we're looking at. So this is a definition for rape that will be reported in the next slide. Rape is completed or attempted unwanted vaginal, oral, anal penetration through the use of, and there are three separate questions that go into this. So physical force, and the example is, and this is directly from the questionnaire, just so you know this. Or in the second question then, so it's physical force. Second question, threats of force, but not actual force. And then the new one in terms of this particular survey relative to the National Violence Against Women survey was when the victim was attempted or completed assault in which the victim was either drunk, high, or drugged, passed out, and unable to consent. Okay, so this is then the frequency of sexual assault, again, rape here. What I'm presenting is really lifetime. The prior slide, 2 slides back, provided what we call incidents, in other words, in the last 12 months. You'll see both, but I'm really focusing on lifetime here. Now what's provided is let's just take the first, well, it's actually the third row across where it says rape with an asterisk. Asterisk, it indicates that we're including, again, from the previous slide, we're talking about forced penetration, attempted penetration, or the drug and alcohol. In other words, inability to provide consent. So about 20%, it's 18% of women are reporting rape as using that definition, and 1.4% of men. So rape clearly much more frequently reported by women than by men. In addition, what is provided, and these are because it's a nationally representative survey, you then can estimate the proportion of individuals in the United States, total numbers in the United States that have experienced this. So you can see they're very large numbers here. Okay, and then I also broke out or pulled from the report the numbers that are reporting forced penetration. Okay, so this is actually then the sexual assault that essentially happened there. All right. This second slide from this data set is now focusing on intimate partner violence. So in the prior slide, that was rape that occurred independent of who the partner was. This is then looking at the range of different types. And I will say I've been in this business, and I wish I was not continuing to be in this business, for about 15 years. And we started with physical violence really being what we focus on. And now, as you can see, the correlated or concurrent types of violence has expanded. A lot of my work has been in looking at the issue of psychological violence, which is a very difficult factor or a construct to really measure. But what you can see here are really just the proportions of individuals that are experiencing the types of violence by categories. 9% of women surveyed are reporting sexual intimate partner violence, that is rape, using the definition previously by an intimate partner, and that cannot be estimated for male populations given the smaller numbers. The other thing I want to call your attention to is the proportion of women that are reporting severe physical intimate partner violence. That's about, again, 1 in 4 or 24%, and about 14% of men. They added in the Newsvids, they're adding a question on the impact, which I think is really important to look at what the particular impact, and they provided on the slide. Then that is, by impact, the number of individuals who reported being fearful, concerned for safety, any symptoms of PTSD, a need for health care. You can read what is included here. That corresponds to almost 30% of women that are reporting intimate partner violence with impact, and 10% of men. So you get some sense then of the frequency here. Now that's looking at people who are 18 and older. Now I'm focusing on some data that we have from 3 colleges. This is a part of an intervention study that we're doing. Yes, ma'am.
I hope it's okay since you...
No, yeah, please.
So in terms of clarification, did this study ask about current and most recent partners?
Yes.
Or did it ask about all partners over the lifetime?
I'm going to back up to answer the question. Yes, they ask about the current partner, which is in this slide where it says past 12 months, okay, that's what we call incidents. So that is the current partner or the experiences they've had in the past 12 months. And
You're talking about lifetime partners, you're talking about all partners.
correct. Absolutely right. Thank you. Yeah. Thanks for that. All right. Okay, so now we're moving on to look at what's going on with a slightly younger population. This is a population of individuals. It's college samples, 3 colleges. We're in the middle of an evaluation of an intervention, and I'm getting ahead of myself, but I wanted to give you some indication of the frequency of violence here. We're using a same survey with three colleges, and we've done this for 3 years. This is the first year of the data, and then we have intervention in the second 2 years. So this is baseline data for us. If we look at any intimate partner violence, and here we're looking at by gender as well as by victimization. So we're asking the questions, and this is actually an online survey in this particular situation, online survey. So about a little slightly over 50% of women are reporting any dating violence victimization, and then just under 50% are reporting perpetration. Now let me just make clear, we in our field use the definitions of victimization, perpetration. We don't use this outside of this room if you want to look at it that way. So we're asking questions about what they experience. That's how we label it as victimization. And then we ask whether they did particular behavior, and that's what we label as perpetration, okay? The individuals who are responding through these questions don't see it as perpetration and victimization, and we do not ask the questions in that way, okay? That was very confusing to me initially, so I want to make clear what's going on there, yeah. Okay. The other thing that's really startling for a lot of us, particularly those people who work in the field as advocates particularly, are somewhat confused and shocked, because you certainly don't see that many men, for example, that are reporting or telling you that they need services, as one example. So this is a phenomenon that has arisen perhaps, and I will perhaps go a little bit further, because of the methodology that we're using, okay? And that is the conflict tactic scale, which we've been talking about. Really is just asking, did you experience it, or did you do the behaviors? We really don't understand well the context of what's going on. So I just wanted to make you guys aware of that, if that's not part of your understanding. It is a struggle to understand that, okay? Because it flies so in the face of what we see. Okay, so the other thing I wanted to call your attention to is I mentioned that early on we're really looking only at physical violence and physical dating violence here. You can see that very similar numbers, and I'm just going to go down the 2 columns for women. 13% of women are reporting physical dating violence and victimization, and also about 13% are reporting perpetration. Okay, they received the behavior or they did the particular behavior. Now you notice 13% is a small fraction, well actually about a fifth of those individuals who say they experience or they use dating violence. That's all dating violence. The difference is psychological abuse, okay, large proportions. And our last speaker really talked about that with regard to 90%, and that is a higher risk population. This is individuals in college that are reporting that of a dating violence, and this is in the past 12 months for the example that was just given. Okay, so you got a sense then of the frequency of violence, victimization by gender. The other thing I wanted to mention, because it really hasn't been talked about yet here, we're seeing it in a lot of college campuses, at least in these 3 locations, is the number of individuals who are reporting that they had a drink that they know was spiked with a compound that basically incapacitated them. Okay, and we asked questions along the lines of whether they were a victim, this happened to them, or in the second category in terms of the perpetration here, the question is phrased is, did you put something in someone else's drink, not just specifying what it was, or did you know someone who has? So when we say perpetration, it's not, we're inviting them to talk about the potential behaviors, not necessarily labeling them as the person who did that, okay? So you can see the proportions that are provided there. Okay. Again, there's a lot more I could talk about, but this is just giving you the idea of the frequency in a younger population. Okay, so now we go even younger. This is a study that was funded by the Centers for Disease Control and Prevention. Okay, And what we're looking at here is we're evaluating a primary prevention intervention. So I want to be cut to the chase and provide you some estimates of dating violence in a younger population. We've been doing this study for 3 years again, right around 18,000 individuals. We go to 26 high schools across Kentucky. One of our earlier speakers talked about how rural Pennsylvania is. Just move over a couple states, very rural in Kentucky, let me tell you. And we've been all over Kentucky. So this again provides the frequency of dating violence, and we're using very similar tools to the previous slides. You can see here victimization and perpetration, slightly lower rates of dating violence. Again, we're looking at psychological abuse and as well as physical dating violence. And then you'll see these yellow lines, and you probably wonder, why is she putting yellow lines? That's because we're trying to directly compare our rates in our 26 high schools with rates, and these are the yellow lines of the YRBS data from the year immediately previous to our doing this survey for the Youth Risk Behavior Survey in Kentucky. Okay, so Kentucky has slightly higher rates of dating violence based on the YRBS numbers, and they've been creeping up. And so you can see that actually in terms of the direct comparisons, the physical dating violence, the physical DV that you'll see there for girls, we're actually seeing slightly lower rates in our 26 schools than the YRBS. And actually the same is true, but more dramatically, for the forced sex question. The forced sex question that I'm including here is exactly what's on the YRBS, and we actually have lower rates than are reported with YRBS data. Now, I should also say with these 26 schools, these are all schools that our Rape Crisis Network has good relationships with. So there may be some effect, actually, of that connection with the rape crisis centers. Okay. All righty. So now I was asked to provide an overview of the health effects of intimate partner violence. Now let me just say there are entire books, and in fact I'll direct you to one of those more recent books. This is actually from a chapter, and this is really looking at how it is that intimate partner violence can be associated with a range of different mental health outcomes. My children always say to me, "Mom, you know it's bad for you." Well, it is true. And however, we need to spend time working through this. So let me just briefly go through this. We know there are a range of different types of intimate partner violence: physical, sexual, psychological, stalking, coercion and control. All of those factors may, as part of really that construct of intimate partner violence, may be associated with an economic burden, and that could be iterative. In other words, that an individual could experience violence and then get out of the relationship, then the income being lowered, or it could be that income may influence the risk of intimate partner violence. That's a hard one for us to disentangle. Either way, that could be related to adverse mental health and physical health conditions. One of our earlier speakers talked about the role of intimate partner violence during pregnancy or in reproductive time periods, and that's really the middle box here in terms of intimate partner violence may be associated with risk-taking behaviors. We frequently look at the risk-taking behaviors of the woman, but we also need to remember that is not occurring in a vacuum. There are risk-taking behaviors of the partner as well. And that may be then associated with smoking, substance abuse, may be associated with reduced ability or agency to use contraceptive methods of the woman's choice, may be associated therefore with unsafe sex, might also influence the risk of unwanted pregnancy, and may or may not be associated with increased rates of abortion. We've had a number of, well, at least one talk, two actually, on mental health and the association of intimate partner violence and mental health. What I'm going to do next, after I walk through this whole slide, is really provide kind of a summary of what we know based on a pretty extensive literature review we've done on this topic. Okay, now we move to your left and look at the other physical health consequences, or correlates, I guess we would say. And here we're looking at the reproductive, and by that I mean the very short-term reproductive outcomes either for the infant or for the mother. There are a range of gynecologic health outcomes that are provided there. I will say that there's very, 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 very little literature looking at the effect of intimate partner violence on sexual pleasure. That should be part of what we think about here. And then finally, the whole construct, and not a lot of research done looking at chronic diseases. And that's briefly what I'm going to talk about. Okay. Now, I did mention that there is a recent book on this topic. This was Jackie White, Mary Koss and Alan Kanzen got together and recruited a number of individuals to write chapters for the Violence Against Women and Children, Mapping the Terrain, Volumes 1 and Volumes 2. So a lot of what I'm going to talk about very briefly is in Volume 1 or Volume 2 of that particular set of books, and that's the APA's work. And then also Connie Mitchell and Deidre Engine's book looking at intimate partner violence and health-based perspective is another good book on this topic, just to plug both of those. All right, now we're going to go back to the Newsvids. Not only, Newsvids is really unique because it includes men and women, but they looked at health outcomes in individuals who experience intimate partner violence among women and men. The latter, looking at the effect of intimate partner violence on men, has really not been done. So this is a really significant contribution. Now we're looking at victimization only here. I want to make that clear. We're not looking at perpetration, we're looking at victimization. Okay, I'm going to cut to the chase because you guys can all see numbers here. But for every health effect that's listed here, we can see a -1. For women, and this is by design, I picked them out. There's a whole bunch of health outcomes that are looked at in this particular report, so I'm just making it easy and making it fit on the slide. Okay, so we can see here for the second column over for women, and again for the fourth column over for men, we're looking at among those that experience intimate partner violence, and I'll just walk you through the first row there. 24% of women who experience intimate partner violence are also reporting asthma relative to 14% of women who not experience intimate partner violence. That's about a twofold, not quite a twofold increased risk if you want to look at it that way. We can't technically say risk because we're looking at both concurrently, okay? So pretty much if you look all down that column of intimate partner violence relative to non-intimate partner violence, for all those outcomes, -1, that one difference is hypertension, okay? We see that those whole range of outcomes are associated with intimate partner violence. Notice I said associated because we're not following people forward in time. In fact, that probably would not be ethical to do. So can't really do that. The contribution, as I mentioned, for Newsvids in terms of this particular slide is that we can really look at whether those same health outcomes are associated with intimate partner violence in male victims. And for the most part, minus the first 4 categories, we see that men who experience intimate partner violence, like women, are more likely to have frequent headaches, more chronic pain, more difficulty sleeping, which is associated with depression as well, more limitations of activities, more likely to report their current physical health as poor, and also their current mental health as poor. All right. Now this is the summary of the report that was done in the Mapping the Terrain chapter. You're just going to have to trust me, and you can probably say thank you because I'm reading through multiple pages. This is about 20 pages of a report that we're going through here quickly. So I'm only going to report those that we really find significant associations here, consistently, multiple studies showing the same association. Okay. So in terms of mental health, physical, as well as psychological intimate partner violence are associated with depression, anxiety, postpartum depression in the studies that we're looking at pregnant women, and suicide ideation. Okay. In terms of reproductive or sexual health, intimate partner violence has been associated with chronic pelvic pain consistently, with menstrual irregularity, with cervical neoplasia in the few studies that have looked at that, certainly with sexually transmitted infections very, very consistently there, with perinatal mortality, fortunately in this country a rare event. Also low birth weight and a range of selected maternal complications, particularly injury and hospitalizations that are resulting from injury. In terms of the cardiovascular or chronic health conditions, beyond what we just talked about in the previous slide. There's some indication that intimate partner violence is associated with heart disease, hypertension, not as clear, stroke, a range of different GI disorders, and chronic fatigue and arthritis. All right, last of the laundry list here before we get into what works and what might work. This is a report, and there have been more recent reports. I think this is a really good one in terms of providing us an overview of the cost of intimate partner violence. And I'm really going to cut to the chase and just basically say this number, $8 billion. Okay, I know. To me, that's like say no more. Okay. This is a report that was done by the Centers for Disease Control and Prevention, reported in 2003, based on the National Violence Against Women survey. I suspect that there will be another report coming from Newsvids in the not-too-distant future. All right. And I'm okay time-wise. All right. So now I'm going to move to the intervention research. And I'm going to cover this in terms of tertiary, secondary, which is the topic for the day, and very briefly, because Michelle told me to, talk a little bit about primary prevention from that perspective. Okay, I'm also aided by a recent report, as in like came out yesterday, not this yesterday, but this past week, and we'll talk very briefly about that. Okay, so as you all know, when we're talking about, and I'll do this quickly, when we're talking about tertiary prevention, we're really focusing on survival, harm reduction, and risk reduction, and also intimate partner violence recurrence. The violence has already happened. We're trying to save people, if you want to look at it in that way. This has really been the mainstay of the women's movement, really, really essential work, and I don't want anybody to discount it. We need tertiary prevention to continue, okay? So the settings for that has primarily been legal, social service, and now, more recently, healthcare settings. Okay, so the first one is a quick review of actually two papers. This is work that's done by my friend Judy McFarlane in Houston area. And in this one, she's looking at the relative efficacy of two interventions to increase safety behavior. So the outcome here is safety behaviors exclusively. These are women who are coming into the district attorney's office to apply for a protective order. And this is a reasonably fun size study. You have 75 women. These are not randomized, so they're basically individuals who are coming in. They are then, at that point in time, randomized into two groups, either usual care, which is providing them a wallet-sized card with the Houston Area Women's Center information, or they are randomized to a telephone-based intervention. Okay, and these individuals then are followed, and Judy is great with her follow-up rates. I mean, she gets 80 to 90% of her cohort to continue to do these surveys over time. She gets the prize, in my opinion. It's really, really hard work, and she can do a great job on this. So let's see. So they're following it at 3, 6, 12, up to 18 months, and she's finding significantly more behaviors, safety behaviors, in those individuals who got the intervention relative to usual care. So evidence here from a tertiary prevention, everybody's experienced violence, that safety behaviors increase. Just looking at safety behaviors here. Now we're going back in time a little bit. This was a study that was published by Sullivan and Bybee, and this is a really, really important study in terms of the importance of, again, shelters and all the good work we do in shelters. So let me just say, from an evaluation perspective, there's a lot of good work that is done in our community, okay, to provide services to women that we never evaluate. All right, so I'm just telling you what there are numbers associated with. There's a lot of good work that's not included in these intervention studies that have evaluation components. All right, in this particular one, this is based in a shelter, and it's to determine the effect of advocacy counseling. You're going to hear advocacy coming up several times in the next about 15 minutes. And this is a study that was done as women are leaving the shelter. So they received the services. They had to have been in the shelter for at least one night. Okay, and then there are two groups. One is the usual care, who received no counseling subsequent to the shelter stay. And then the intervention group, over a 10-week period, got one-on-one counseling. Okay. The results were then the intervention group who got this longer-term one-on-one counseling reporting over time, and they're followed for 24 months, another long-term, so that's really pretty long-term. Reported less violence and lesser abuse over that time period relative to then the usual care group. The intervention group also reported more effective leave-taking behavior, if you want to look at it in that way, and improved quality of life. Yet there were no differences in the two groups in terms of depression or psychological abuse over time. All right, now, I feel like I am running here. Okay, now we're looking at the question of the day, which is secondary prevention, which typically is looking at harm reduction, and the focus is on screening. This has typically been screening in a healthcare setting, workplace, or an educational setting. Okay. Now, I want to also make this clear, that when we're talking about screening, it's a little bit different than what we talk about when we talk about screening for cancer or mammograms. Everybody probably in this room, except two people, have had mammograms or pap smears. Okay. That's screening before the cancer has happened for the most part, or when the very small cancer. Here, we're talking about screening for people who may have experienced violence over a longer period of time. So it's not exactly the same, but we're going to think about it in a similar construct here. And you've actually had some of the previous speakers are already talking about the sensitivity and specificity of some of the screening tools. I'll briefly mention that as well, and I thank my colleagues for talking about that. Okay, so there are some real challenges, as you will hear later, and you'll hear some right now, in terms of how to screen. There are a range of tools to screen. There are also a range of different types of violence to screen for. We've talked about physical, others have talked about sexual violence, psychological abuse, or some examples. The timing, and we had a good question in the back about timing. Are we interested only in current? Would we be interested in lifetime? There are real issues along that line in terms of what health effects we are trying to impact. In addition, we were talking about this last night. How to screen. Do we do this using computer-assisted devices? Is it one-on-one screening a better setting? All those kinds of things I'm thinking about or calling the mode of screening. Now, in terms of looking at how do we evaluate this? What works? We've had several examples in terms of the tertiary prevention kinds of approaches. How do we measure what's the ultimate goal? We want violence to stop. Okay, yes, we do. Do we want to look at improved safety? Are we looking at health? Are we looking at help seeking? Okay, so I'm also going to provide a brief review of efficacy studies along this line. I'm cutting to the chase here because I need to, and that is, what's the bottom line with screening tools? I also have a report that I'm going to tell you about that provides cutting to the chase with a little bit more detail here. Okay, universal screening is best. What do I mean by universal screening? That means screening everybody, not people that the physician or the nurse suspects. Screening everybody. It's really hard for healthcare providers, medical care providers is a better way to say that, to do that, but that's really where you'll have probably the most benefit. Psychological violence does have consequences, okay? We also need this tool to be brief. Now, I will say, I work with a lot of psychologists, so Courtney, don't listen here for this second. And brief means 3 to 5 questions. Now, we know there are a lot of issues that we need to screen for. So really, in a clinical setting, it has to be quick. And it's a chore. It's hard to do that, okay? I'm providing some recommendations. Fortunately, these recommendations are validated by the recent report that I'm going to show you in just a second. The abuse assessment screen that Judy McFarlane developed is one of it's very short. There are other instruments that are short as well, and then we do have some now good sensitivity and specificity estimates. Bottom line here is tools do exist. We do not have to at least in terms of intimate partner violence. Depending on the clinic that we're talking about, current intimate partner violence would be the focus. However, if we're looking at, like we're working in a cancer clinic, we really want lifetime, including sexual violence as well as childhood sexual violence, okay? Annual screening is recommended, except in prenatal care. Clinics, ACOG recommends actually screening at the first visit for prenatal care, as well as each trimester, including the 4th trimester. For those of you who've had kids, the 4th trimester, just so as not to scare you, that's the postpartum visit, okay? All right. I'm not going to say that nurses are the only ones to screen, but I will say nurses have certainly led the way in screening for intimate partner violence and sexual violence. All right, this is my quick and dirty in terms of the screening modalities. There is evidence to suggest that self-administered screening, I use my prop again, appears to be preferable in terms of the numbers of the increased proportion of women who will disclose intimate partner violence. Also, there are studies that show that that is a preference for women, and it's also easier for clinicians. Okay, just get that out. However, when you get a yes answer and you're not you in the global you are not following up with that individual, or your electronic device has a hard time following up with an individual, that face-to-face really is the best in terms of that transition into intervention, which is the whole point of this, right? Okay. I think I'm speaking to the choir here. The majority of women do accept clinical and self-administered intimate partner violence screening. Okay. All right, so this is the report that just came out, although it says June 5th of 2012. You're going to see several different June deadlines. Next month is going to be a great month, just to predict this for us. It's a lot going on. This is a report that is really an update, if you will, of Heidi Nelson, again, first author on this, a systematic review update of the 2004 U.S. Preventive Health Task Recommendation. Just to remind you, there was an I recommendation indicating that there's insufficient evidence for or against family violence, including elder abuse and intimate partner violence. So they went back to the literature one more time, and very, very similar approach in terms of using Medline and PsycInfo for those range of days. You can see all that up there. They're reviewing new data specifically in terms of the efficacy or the effectiveness of screening and interventions in healthcare settings, and then the diagnostic accuracy of the screening instruments themselves, and then the new component is really looking at the adverse effects of screening and intervention. And I would like to say, for those in defense of all of us in the room who work in this area, we paid attention when they said there's not a lot of evidence or a lot of work going on looking at the adverse effects. We provided them with that information, so yay for us. Okay, so. All right, so this is a figure just for those of you who may not be aware of evaluation. I'm not going to go over it in great detail, but really what we're talking about is looking at the ultimate outcome of reduction of exposure to violence and a reduction in the physical harm. Here we're talking about, in terms of that evaluation of the I report, we're really talking about screening versus no screening. Not looking at an intervention, just the effect of screening versus not screening in terms of reduction in violence. All right, so I am cutting to the chase yet again in providing one slide for that report. You're going to have to trust me, okay? There is, and let me also say that I'm using the language of the authors. So there is one large, fair quality randomized clinical trial of screening versus usual care. There is only one study that has been done. That's Harriet McMillan's work, and that was done in Canada, and Andrea, that was funded by Canadian government. We had that conversation last night, and I'm going to talk about it in the next slide. Okay, there are also, again, I'm following with what was the focus of this particular review. There have been 15 fair to good quality studies that are evaluating 13 instruments, and I'm really, again, just summarizing what's provided here. There are 5 instruments that have high sensitivity and specificity. Thanks to Dr. New. You already know what sensitivity and specificity are. The higher the sensitivity and specificity, the better the scales. So those are provided here. The HITS, the HARC, the Abuse Assessment Screen, Ongoing Violence Assessment Tool, and the Women Abuse Screening Tool. I've already provided some of those in the past. So we have good screening tools. That's the bottom line here, okay? There are 4 fair to good trials on counseling or advocates in clinics and other settings. In summary, in terms of those, the effectiveness of those four, we see a reduction in intimate partner violence associated with improved birth outcomes. Michelle Kiley's work, I'll show you that really quickly in a second. A reduction in intimate partner violence for new mothers followed over time. Again, Michelle's work. And Liz Miller's work as well, looking at a reduction in pregnancy coercion and unsafe relationships for women in family planning clinics. Okay, there are 14 studies that indicated minimal adverse effects of screening. This is what I'm saying, that we responded to the call by the earlier report. And examples of those adverse screening effects are discomfort of women, loss of privacy, emotional distress, and concerns about future abuse. All right. So this is the best evidence that we have. Large clinical trial, again, conducted in Ontario. Several clinics that were included, 26 either emergency departments, family practice settings, OB settings. Large in that there were almost 7,000 female patients screened between the ages of 18 and 64. This was done in 2005 to end of 2006. They were individually screened. The women were screened, everybody, almost 7,000, were screened using the women's abuse screening. They were randomized to receive the screening before the clinic visit or after. Okay, that's an important design issue. And then the healthcare provider had the option, if a person screened positive, to then follow up in terms of discussion. I'll just tell you very briefly, from the discussion in the paper, not all of in fact, a minority of the clinicians actually went back and talked to the person who screened positive. Okay, but they all were, the half that were randomized to the screening got the screening before the visit, and the remainder got the screening after the visit. Okay. All right, that group was then followed at 6 months intervals. Those that agreed to the follow-up, and these are all people who experience intimate partner violence, were then followed at 6-month intervals up to 18 months. I've done a study like that. It's a hard study to do, to continue that follow-up, so it's fairly long follow-up. They did experience, as most of us do, except Judy McFarlane, experience high rates of loss to follow-up. And you can see what was presented there. Now, in terms of the results, at the 16-month follow-up, there were no difference in IPV. So we're looking, again, at outcome being, did intimate partner violence reoccur? Is it still occurring? The recurrence rates was actually lower in those people who were screened before the visit as opposed to after, but there were not statistically significant differences. There was also no difference over time in the quality of life in the screen before versus screened after. And the last issue is important in terms of the issue of harm of screening. There were none of the screened women reported harms of screening itself. Yeah. Yep. Mm-hmm.
I was a consultant.
Yeah, please.
I know the ins and outs.
Yeah.
I think it's really, really important to understand that the providers were trained on how to do very personalized, very specific and in-depth referrals for women and get them to a social worker if there was a social worker at that site, depended on the site whether or not there was one, to get them advocacy interventions, because a lot of the sites you could call an advocate and they would come. So they were all trained on that, and the providers all got a printout that said, this woman has said she's abused. According to the women, the majority of the providers never said a word about that printout. So I think it's really important to understand in this trial, and Harriet interprets that finding a little bit differently than I do, because she said the trial is of screening. And I'm like, and everybody, both those who were screened and those who were not screened, got referral information for domestic violence services. So everybody got a referral. And so basically, people were just asked, but not given anything more in the intervention group. And I think that's really important when we think about the results of this trial. So basically, everybody got, and it's just that the women in the control groups got asked about domestic violence later.
Yeah.
And got referrals, and both groups had a decrease. It just wasn't significantly different in the two groups, which I say, well, duh. Of course it wouldn't be. Anyway.
Thanks, Jackie. You guys are so lucky. The wealth of information that you have in this room. Thank you, Jackie. That was very kind of you. Okay. So I'm just going to say that I've been involved. I now know how difficult it is to do one of these trials. You'll see very quickly, and I'm about to run out of time, a couple of studies that we've been doing in the OB department and the University of Kentucky. And this is a study that's coming out in obstetrics and gynecology also in June, that famous month coming up. And I'm just going to cut to the chase in this. We implemented universal screening, so everybody was screened. We trained nurses to do the screening. It's not a randomized trial because we're basically looking at those individuals who are new to the clinic, our new OB patients, relative people who were seen prior to implementing the screening. So it's a retrospective cohort design. We did, though, see, and just to provide this to you, we did see in the two different populations that pregnancy outcomes were better among those that received universal screening relative to those that did not. And that was true for increasing birth weights in the universal screen versus those that were not. Also in terms of gestational age, greater gestational age at delivery, higher APGAR scores, and also number of maternal complications. All right. I mentioned Michelle Kiley's work, and you can briefly see, and I'm going to cut to the chase in terms of the results here. Here, again, women were randomized to an intervention versus a comparison group. The women that were randomized to the intervention were less likely to have recurrent intimate partner violence, so the outcome was whether the violence was continuing to occur or occurred again at the postpartum visit relative to those who had not received or got usual care. And also the intervention has significantly fewer preterm neonates and other rare events in this study, and an increase in gestational age. So we have similar findings along those lines. Jackie McFarlane, again, done a lot of work in this area, and basically she's looking at groups of individuals. These were Hispanic women in the Houston area, got one of 3 interventions, and I'm going to cut to the chase and tell you basically that at the 2-month follow-up, the scores on this is the Severity of Violence Against Women survey, Linda Marshall's survey, intervention scores were significantly lower in the outreach group compared to the counseling group. And then these individuals, again, were followed up to 18 months, and the scores were lower in all groups, but the scores did not differ by intervention. So this actually kind of gets to the point that Dr. Campbell was mentioning, that actually intervention alone does improve outcomes. And it really doesn't matter whether the intervention doesn't matter, it's actually asking that may matter. Okay, and then there's another work that's done, since we have some people from primary care here. This is another set of studies that Judy McFarlane did. This is a randomized clinical trial in a primary care setting, again in Houston. And this for 2 groups. One was randomized to receive that Gann-Waltz-size card relative to a 30-minute nurse case management intervention. And very, very similar findings to the study that she's done in the OB clinic. All right, this is another study that's actually is coming out in Violence Against Women again in June, and this is a study that I was involved in South Carolina in another very rural setting, and we had an advocate intervention. Advocates were randomly assigned to different clinics, and we followed them over time for 24 months, and we found a reduction in depression over time with the advocacy intervention. All right, let me check on my time. I have 15 after. I'm okay? All right. So now we're moving into primary prevention. And I've got a couple of studies that have been published in this area in terms of what worked. This is actually reviewed in the Mitchell book that I mentioned previously, and Dan Whitaker was first author on that, reviewing a range of different things that may work. There are two that the CDC has reviewed and deemed as providing evidence that worked. This is another Canadian study. Wolf is the first author on that, and this was published in 2003. This is in primary prevention in communities, and this is actually community-based interventions with high risk, and we've had some conversations about high-risk teens just previously. And we're looking at here 14 to 16-year-olds that have a history of child maltreatment. They're randomly assigned then to an intervention or no treatment or a non-intervention group. The intervention consists of education about healthy relationships or abusive relationships, conflict resolution, communication skills, and social action activities. What they found was, and this is using unconditional growth models of abuse perpetration, and that's following the individuals over time, they're finding reduction in physical abuse of the dating partner over time, and also emotional abuse, so physical emotional abuse. And the effects was stronger for girls than for boys. Okay. All right, and that's number one. Number two is safe dates. Vanjie Foshi's work was done in rural coming up, rural North Carolina, and this is in a middle school population. And in this situation, there was the schools were randomized to, or individuals in schools were randomized to the Safe Dates curriculum. Safe Dates curriculum involves 10 45-minute sessions that are taught either by the health or physical education teachers. Frequently those people are the same people. And in addition to the curriculum that's delivered in the schools, there also are other activities, and here are poster sessions, and then they had a theater production as well. The individuals that were then followed up to 3 years, and the randomized sample then intervention there was a booster session as well. So the data collection was at baseline, 1 month, and then year after for 4 years. So really fairly long follow-up for those individuals. All right, what they found was that they saw a reduction in psychological, physical, and sexual dating violence perpetration, and a moderate reduction in physical dating violence victimization. Okay. The other important thing here is, and this is for the geeks in the audience, that would include me, that the program effects are mediated by changes in norms as well as gender-based roles and awareness. So that basically translates into the theoretical model held out in terms of how violence should be affected with regard to this intervention. All right. Because Dr. Decker asked me to, I'm going to provide a little bit of data, and this is, again, hot off the computer. Of one study is published, and one is where we're still working on. This is some work that we're doing at the University of Kentucky, and I will say that everybody in the room is going to wish that Dorothy Edwards was here doing this presentation right now, but you have me. So this is a map of Kentucky, if you did not know. And the concept here is anybody familiar with active bystanding or bystanding interventions? Most people are, okay. So it's basically engaging others in violence prevention. And Dorothy would explain it. She would stand in the middle of the room and she'd tell you basically that we all have responsibility for violence prevention, okay? So we may not use that power. So the idea of green dot, and the green dots are those stamping out the red dots. The red dots are the violence that we've been talking about. And the green dot is the intervention that we each can uniquely do. Okay, so a lot of what we're trying to do at the University of Kentucky, and we are not alone. This is not just, we're not the only people doing this. Let me make that clear. We just have this name. Unfortunately, there are other people who have the green dot name too, so it's a little confusing in Kentucky right now. But so it really is we're evaluating the engaging others in violence prevention. That's the concept here. Okay, so this is we have 2 studies going on. They're both 5-year studies. One is in college settings, and remember I talked about earlier on the 3 college survey. So we're doing this in one college, comparing it with 2 other colleges. That means we only have a sample size of 3. We may have 8,000 people in each of those, but we have a sample size of 3. That hurts my heart as an epidemiologist. It's a lot of work for 3, sample size of 3. So basically what we see is we're doing surveys. These are using Zimmerang, so it's all electronic, but these are college students, and they're very engaged in this. I am cutting to the chase to say that, and this was published in Violence Against Women in 2011, a special issue on active bystanding or bystanding interventions. We see that with the intervention, and I'm really only measuring here the effect of the intervention that is SEEDS training, which is the active bystanding training, and then Green Dot speech alone. So both of those interventions do, and they are related, do reduce the social norms of the rape myth acceptance is a measure of social norms, so that you see lower social norms in those people who are trained, and we see increased active bystanding scores, and bystanding go up as you get more training. We also are funded by the Centers for Disease Control. I'm just really going to briefly provide you with the slides. Big study, 26 high schools across Kentucky. Half of them are randomized to the intervention, half not. And this is the hot off the press. We have a special issue of Violence Against Women that's coming out early next year, in which we're providing a lot of the baseline data in terms of frequency that you have seen it here first today. This is the 3rd year of the study, and this is the first year we have full implementation. And just cut to the chase to say that with the intervention, we see a reduction in social norms that are associated with intimate with the dating violence and also sexual violence, and we see an increase in bystanding as we see an increase in training. All right. Thank you for your very kind attention. Do you have questions?
A slide had shown about screening in education and work settings, and I was wondering if you could talk a little bit more about that, what that looks like.
We probably have some experts in the room. Who is Nancy Glass? Asking about interventions in workplace settings.
Okay. What was the question? I'm sorry.
Just as we talk about interventions in healthcare settings, what would it look like in education or workplace settings?
So we have a couple projects going on in the state of Oregon right now, and have focused on computer-based training for supervisors. Oregon is one of 13 states that has a unpaid leave, protective leave law for victims of crime, domestic violence, stalking, and sexual assault. So what we have found is most women, primarily women that we've interviewed, had no idea that their state had this law. And so, and many of the reasons why they don't take leave is because they're afraid of losing their job, or actually work is the safest place they could be, too, in many cases. So we've been trying to do interventions to develop workplace policies, change the culture of the workplace, so that, one, there's information about existing laws and resources in their settings, that there's actual policy that addresses the perpetrator in the workplace, because sometimes the worker is the perpetrator. And we're also doing training for supervisors around existing resources. And so what we've been doing is linking in computer-based training right at the work site, so that folks have it easily accessible through, and it's also through the internet. So that's one of the studies we've been doing. We're also targeting home care workers. So unions, we're working with the unions as well as to try to advocate for policies to reduce violence against women, primarily women who are going in to provide home care.
Thanks. Thanks, Nancy.
Hi, more than a question, I just want to offer a resource. My name is Alessandra Guedes. I work for WHO, the Regional Office for the Americas. And in 2010, WHO and the London School of Hygiene produced a review of evidence around primary prevention of intimate partner and sexual violence across the lifespan. So that's a document that's available. It doesn't include the most recent information that we've seen, but it includes a lot of other information that may be useful.
Thank you.